Welcome to Pediatric Case Review. In today's lecture, we will provide an introductory overview of spina bifida in children. This presentation aims to help healthcare professionals identify key clinical presentations, understand diagnostic approaches, and recognize appropriate management strategies for children with spina bifida. Let's begin with our first case. A newborn presents with a visible sac-like protrusion on the lower back. Which is the most likely type of spina bifida? Is it A. Spina bifida occulta, B. Meningocele, C. Myelomeningocele, or D. Lipomyelomeningocele? The correct answer is C. Myelomeningocele. This is the most severe and common form of spina bifida, accounting for about 80% of cases. It involves the protrusion of meninges, spinal fluid, and neural elements through the vertebral defect. This condition is readily visible at birth and requires urgent neurosurgical evaluation and intervention to prevent infection and further neurological damage. Our next case involves a 2-year-old with known myelomeningocele who presents with lower limb weakness. Which additional finding would you most likely observe? A. Normal bowel and bladder function. B. Neurogenic bowel and bladder. C. Increased head circumference only. Or D. Normal sensory function below the lesion? The correct answer is B. Neurogenic bowel and bladder. Children with myelomeningocele commonly experience disruption of neural pathways that control bowel and bladder function. This disruption leads to incontinence, urinary retention, and constipation. Early urological assessment is essential to prevent complications such as urinary tract infections, vesicoureteral reflux, and potential kidney damage. Management typically includes clean intermittent catheterization and bowel management programs. Now let's focus on examination findings. During examination of a 1-month-old with suspected spina bifida occulta, which finding is most likely to be present? A. Large open defect on the back. B. Tuft of hair, dimple, or discoloration over the lower spine. C. Complete paralysis of lower extremities. Or D. Visible cerebrospinal fluid leakage? The correct answer is B. Tuft of hair, dimple, or discoloration over the lower spine. Spina bifida occulta is often not visible externally, but may present with cutaneous manifestations that mark underlying spinal abnormalities. These include a patch of hair, skin dimple, hemangioma, or skin discoloration over the affected area. These findings warrant further investigation with ultrasound in infants or MRI in older children to rule out tethered cord or other associated conditions. Let's examine another case. A 3-year-old with repaired myelomeningocele has asymmetric lower extremity strength. Which additional finding would you most likely discover on examination? A. Hypertonia with increased deep tendon reflexes. B. Symmetrical sensation in all dermatomes. C. Flaccid paralysis with absent reflexes below the lesion. Or D. Normal gait pattern? The correct answer is C. Flaccid paralysis with absent reflexes below the lesion. Children with myelomeningocele typically exhibit lower motor neuron dysfunction at and below the level of the lesion. This results in flaccid paralysis with reduced or absent deep tendon reflexes rather than spasticity. The level of neurological impairment directly correlates with the anatomic level of the defect. Sensory deficits generally parallel motor deficits, and both contribute to challenges in mobility and functional independence. Moving on to pathophysiology. During which embryonic period does the neural tube defect leading to spina bifida primarily occur? A. 1 to 2 weeks of gestation. B. 3 to 4 weeks of gestation. C. 10 to 12 weeks of gestation. Or D. 20 to 24 weeks of gestation? The correct answer is B. 3 to 4 weeks of gestation. Spina bifida results from failure of the neural tube to close properly during early embryonic development. Neural tube formation and closure occurs between day 21 and day 28 after conception, often before a woman knows she is pregnant. The posterior neuroport typically closes last, and failure of this closure results in spina bifida. The etiology is multifactorial, involving both genetic predisposition and environmental factors, with folate deficiency being a significant modifiable risk factor. Let's discuss investigations. A pregnant woman at 16 weeks gestation has an elevated maternal serum alpha-fetoprotein. Which is the most appropriate next step? A. Immediate delivery. B. Targeted ultrasound assessment. C. No further testing needed. Or D. Amniocentesis only? The correct answer is B. Targeted ultrasound assessment. Elevated maternal serum alpha-fetoprotein is a screening test that suggests increased risk for neural tube defects. The appropriate next step is a detailed anatomical ultrasound to visualize the fetal spine and identify open neural tube defects. Modern high-resolution ultrasonography can detect approximately 95% of open spina bifida cases. If ultrasound findings are inconclusive, amniocentesis for measurement of amniotic fluid alpha-fetoprotein and acetylcholinesterase may be considered for confirmatory diagnosis. Our next case involves a newborn with repaired myelomeningocele who requires imaging to evaluate for hydrocephalus. Which imaging modality is most appropriate? A. X-ray of the skull. B. CT scan of the head. C. Cranial ultrasound. Or D. PET scan of the brain? The correct answer is C. Cranial ultrasound. In neonates, cranial ultrasound is the preferred initial imaging modality to evaluate for hydrocephalus. It is non-invasive, does not expose the infant to radiation, can be performed at the bedside, and provides good visualization of the ventricular system through the open fontanelles. This allows for assessment of ventricle size and serial monitoring of ventricular dilation. While CTs can also visualize as hydrocephalus, it involves radiation exposure and is typically reserved for situations where ultrasound is inadequate or additional information is needed. Now let's discuss treatment approaches. A newborn is diagnosed with myelomeningocele. What is the most appropriate timing for surgical repair? A. Immediate repair within 24 hours. B. Delayed repair after 6 months. C. Repair only if neurological symptoms develop. Or D. No repair necessary? The correct answer is A. Immediate repair within 24 hours. Early surgical repair of myelomeningocele is the standard of care and should be performed within 24 to 48 hours after birth. This timing reduces the risk of infection and prevents further damage to exposed neural tissue. The surgical procedure involves multi-layer closure of the defect with careful preservation of neural elements. While surgery cannot restore neurological function that is already lost, it prevents further deterioration and reduces the risk of complications such as meningitis. A 2-week-old with repaired myelomeningocele develops progressive ventricular dilation on ultrasound. Which intervention is most appropriate? A. Conservative observation only. B. Medical management with acetazolamide. C. Ventriculoperitoneal shunt placement. Or D. Repeated lumbar punctures? The correct answer is C. Ventriculoperitoneal shunt placement. Between 70 and 90% of children with myelomeningocele develop hydrocephalus requiring treatment. Progressive ventricular dilation with signs of increased intracranial pressure requires cerebrospinal fluid diversion, most commonly via ventriculoperitoneal shunt placement. While medical management with acetazolamide has been tried historically, it is not effective for long-term management. An alternative approach in selected cases is endoscopic third ventriculostomy with choroid plexus cauterization, which may avoid shunt dependency and its associated complications. Let's discuss complications. A 5-year-old with spina bifida has recurrent urinary tract infections despite clean intermittent catheterization. Which complication is most concerning? A. Vesicoureteral reflux with potential renal damage. B. Urethral stricture. C. Bladder calculi. Or D. Urinary incontinence alone? The correct answer is A. Vesicoureteral reflux with potential renal damage. In children with spina bifida, preservation of renal function is the primary goal of urological management. Neurogenic bladder dysfunction can lead to high intravesical pressures, vesicoureteral reflux, and recurrent urinary tract infections that ascend to the kidneys. This combination can cause pyelonephritis and permanent renal scarring. Management includes urodynamic studies to assess bladder function, anticholinergic medications to reduce detrusor overactivity, and surgical interventions such as vesicostomy or bladder augmentation in refractory cases. Our next case involves a 7-year-old with myelomeningocele who develops progressive foot deformity and hip dislocation. Which factor most contributes to these orthopedic complications? A. Vitamin D deficiency. B. Muscle imbalance and decreased mobility. C. Excessive physical therapy. Or D. Growth hormone excess? The correct answer is B. Muscle imbalance and decreased mobility. Children with myelomeningocele develop orthopedic complications primarily due to neurological deficits that create imbalanced muscle forces across joints. This imbalance, combined with decreased weight bearing and mobility, leads to progressive deformities such as clubfoot, hip dysplasia, and scoliosis. Management is multifaceted, including positioning, bracing, physical therapy to maximize function, and surgical interventions when necessary. The goal is to maximize mobility, prevent contractures, and establish a stable, plantigrade foot for ambulation with orthoses when possible. Let's discuss associated conditions. An infant with myelomeningocele develops stridor, swallowing difficulties, and apneic episodes. Which condition most likely explains these symptoms? A. gastroesophageal reflux disease. B. Laryngomalacia. C. HERE2 malformation with brainstem compression. Or D. Tracheoesophageal fistula. The correct answer is C. HERE2 malformation with brainstem compression. HERE2 malformation is present in approximately 90% of children with myelomeningocele. It involves downward displacement of the cerebellar tonsils, brainstem, and fourth ventricle through the foramen magnum. When symptomatic, it can cause brainstem dysfunction manifesting as stridor, swallowing difficulties, apnea, and cranial nerve palsies. These symptoms represent a neurosurgical emergency requiring prompt evaluation and possible posterior fossa decompression to relieve brainstem compression and prevent potentially life-threatening complications. Let's discuss prevention strategies. A woman planning pregnancy asks about prevention of neural tube defects. Which recommendation is most effective? A. Folic acid supplementation starting 3 months before conception. B. Avoiding all medications during pregnancy. C. Ultrasound screening only. Or D. Genetic testing for all couples? The correct answer is A. Folic acid supplementation starting 3 months before conception. Multiple studies have demonstrated that periconceptional folic acid supplementation reduces the risk of neural tube defects by 50 to 70%. The recommended dose is 400 micrograms daily for women at average risk and 4 milligrams daily for women with previous neural tube defect-affected pregnancies or those taking anticonvulsants. Supplementation should begin at least 3 months before conception and continue through the first trimester of pregnancy. Food fortification programs have contributed to significant reductions in neural tube defect incidence at the population level. A 10-year-old with spina bifida requires long-term follow-up. Which approach is most appropriate for comprehensive care? A. Neurosurgery follow-up only. B. Primary care physician management only. C. Multidisciplinary spina bifida clinic. Or D. As-needed specialist referrals when problems arise. The correct answer is C. Multidisciplinary spina bifida clinic. Children with spina bifida have complex, multi-system needs that are best addressed through coordinated care in a multidisciplinary setting. These clinics typically include neurosurgery, urology, orthopedics, physical and occupational therapy, orthotics, developmental pediatrics, nursing, and social work. This model allows for proactive surveillance of potential complications, coordinated care plans, and reduced burden on families. As children approach adolescence, transition planning becomes important to ensure continued comprehensive care into adulthood with attention to independence, self-management, and reproductive health. Thank you for joining our lecture on spina bifida in children. We've covered the clinical presentation, examination findings, pathophysiology, investigations, treatment approaches, and associated complications of this complex condition. Remember that spina bifida requires early intervention and lifelong multidisciplinary care, with folic acid supplementation remaining our most effective prevention strategy. Please follow Pediatric Case Review for more informative presentations on pediatric conditions. If you have any questions or topics you'd like us to cover in future videos, please leave them in the comments section below.